Hello, this is Dr Helen Webberley. Welcome to our GenderGP podcast, where we will be discussing some of the issues affecting the trans and non-binary community in the world today, together with my co-host, Marianne Oakes, a trans woman herself, and our head of therapies. We have two surgeons with us today, two UK-based surgeons who are both very experienced and talented in top surgery. So I'm really delighted to welcome both of you. We have Mr. Ntanos and Miss Chloe Wright, two surgeons. So I'm going to let you introduce yourselves, just to tell us who you are, why you ended up having a specialism in top surgery, which is what we're talking about today, and any golden nuggets that you want to start with. So Ioannis, if you don't mind, I'll call you Ioannis. Introduce yourself and tell us who you are, and welcome to GenderGP.
That's absolutely fine. Thank you very much. Hello, everyone. So yes, my name is Ioannis Ntanos. I'm a breast-trained surgeon, but focusing on top surgery for the last 3.5 years since I joined the team in North Manchester. My exposure to top surgery started with me moving to Manchester, but from the first moment I was extremely interested in it, not only from a surgical point of view, but from an ethics and health policy point of view too. And this is solely during the last 3.5 years. And I was trained under the lead at the time, Miss De Bridge, who was here in Manchester, and I have recently taken over from her, leading the services at this point. Thank you.
Welcome. And Miss Chloe Wright, nice to have you. Introduce yourself.
So thank you for having me with you. So I'm Chloe Wright. In my current position, I'm a consultant oncoplastic breast surgeon, but I'm delighted that in the new year I'm going to be joining Manchester General Hospital, and that will be in the delivery of care for people who are seeking their gender confirming top surgery. I had the benefit of a really early exposure to this surgery in my training in sort of 2009. And so then through the course of my ongoing surgical training and breast surgery training, it's an interest I further pursued. In my fellowship, my sort of breast surgery and plastic fellowship, I spent time then working with surgeons in different units to develop those skills, and it's been a research interest of mine, particularly at the impact of of gender confirming surgery on health related quality of life. So I'm really excited in the new year to be sort of pulling this together and together with like Ioannis's goals, but to really work to develop pathways, frameworks of care, quality assurance, to really see that we can deliver excellent care for people.
Yeah, that's when we introduced ourselves to each other, about the need for research and the pathways, the frameworks, the quality assurance. These are so important because they're missing at the moment, aren't they?
For sure. I mean, what I recognise completely when, and this was again at North Manchester General Hospital, and it was Janet Wolsey kind of pioneered delivery of this surgery at the hospital there, but it was considered as fringe stuff. It wasn't considered to be sort of mainstream, and it is mainstream. And what I really do more and more of is to recognise that, to see that this needs to be a part of the education that comes through medical school, the education that's part of the FRCS syllabus, so the syllabus for general surgical trainees. And so, really to make sure that it's something of which everyone is aware, but to make sure that we really work out that people who deliver this surgery are appropriately trained and that they have a supportive network of people around them.
Top surgery when it comes to transgender healthcare is different. Skills that are acquired from other specialties can be introduced, but we need to follow a holistic approach. It is a multidisciplinary team approach when it comes to transgender individuals. So there are different things that we take in consideration. If you compare that to any other aesthetic surgery is different, because top surgery for transgender individuals is life-saving. It's more than just life-improving surgery. If you compare it to oncological surgery, it's different because it has a lot of elements to aesthetics. So there are different ways in which we can choose the appropriate surgical technique. Some of them are very distinct. So they have to do with the body type, with the chest size, with the quality of the skin. But others have to do with the individual's preference. And we need always to try and match expectations as much as we can.
Marianne, Ioannis was talking then about this not just being life-improving surgery, but sometimes life-saving surgery. Is that what you've experienced in your therapy room with patients?
Yeah, without question. And another term I use is life-making, because a lot of the people that I see that are preparing for this have got no life. They don't have access to the gym, they can't go swimming, they can't book holidays with their families, they can't go out in the sun, all these simple things that we take for granted is denied them, and the lengths that they're going to hide that part of the body, the extreme binding, the clothes they have to wear, it's so limiting on the life that they have. So, yeah, if we're not saving the life, the very least we're doing is giving them a life. I think what you said there, Ioannis, towards the end, managing the expectations as well. And when I ask people that what's their goal for surgery, they just say, I want a flat masculine chest, and they're worried that that's not enough. And I'll say, no, you don't need to tell me anymore. Why would you not want that? So yeah, managing the expectation, if that's what they can achieve or anything close to it, I think that's brilliant.
So how surgeons, how can we achieve that for patients? I don't know, because I've never been in this operating theatre. I've never seen anything done. How do we manage and create that expectation for patients?
First of all, you have to be focused on the individual's expectations. So in order to match it, you have to have their expectations at the top of your list when discussing surgery with them. This is where we should start with. And this is why transgender healthcare, as Chloe said earlier, should move out from the fringe of breast surgery and focus on becoming an individual surgical specialty, which is not right now. Surgeons who are trained in transgender top surgery have done that individually, but not through a structured curriculum. So first of all, focusing on the expectations, being honest with our individuals, know what to offer them, and try to offer them in a way that it's suitable for them. It's not just about surgical technique. Marianne is absolutely right. These tiny things, being able to go to the gym, enjoy life, are very important. So we might choose a technique over another, the next one, for example, for reasons of minimizing the risk of requiring a revision, even if different surgical techniques are available in the same person.
I think exactly following on from what Ioannis says, it's that although this is a very specific type of surgery, it follows those same principles of discussing any surgery with an individual. It's understanding what they hope to achieve from it and marrying that up with actually what you feel that you can reasonably deliver, recognising what those expectations are and seeing how they can be met. And each individual, their desires, their hopes, their aspirations for surgery, they differ. There are some who are just like, I will be content to be able to wear a t-shirt and, I'll be delighted with that. And then you've got other individuals who are like, actually, I want to be able to strut my stuff with my top off. And so it's really, it's working that out. And then it's saying like, actually, I'm really sorry, but where we are today, you're never going to look like you should be on the cover of Men's Health. And so, it's working these things together so that a person's expectations are realistic, that you're not going to disappoint them, and that, you know, you're working to a point of really, you know, delivering the best that you can for a person. And that's where, you know, there are different surgical techniques that suit a different breast volumes, skin quantity that needs to be excised, nipple position. And, you know, that then each has its trade-off with scarring, that maybe there are potential complications, need for revision. And it's all that sort of extended, true, informed consent.
Mm. So, Chloe, you were talking at the beginning about health-related quality of life and the research and what have you. And I'm guessing that if we're going to be able to move this from a fringe of breast surgery into its own specialty of its own right, then this outcome is really, really important. How can we? Tell me about some of the research you're working on.
So what we recognise clearly in healthcare is we want to see outcome metrics. And the way that we measure them typically is with years survival, it is with serum concentrations. You know, we look at these things, but in something like the gender confirming surgery, you can't measure it in those ways. So the only tool which you can use is then to look at health-related quality of life. It was some time ago now that we did a systematic review to look at what health-related quality of life tools there are specific for this population. And there aren't any that exist that specifically look at top surgery. And if we are in the times as we are, and no country is without it, where, you know, healthcare resources are few, that they're looked to being trimmed down, we need to see that we're getting money's worth out of, you know, our healthcare system. We need to prove that this surgery, you know, we see it, common sense says that the surgery works for people, but we need to demonstrate it and evidence it. And so that's looking at health-related quality of life outcomes. There have been some studies looking at quite specific body image related quality of life, sexual functioning. The group working from Amsterdam looked specifically at this for chest contouring surgery and showed really positive outcomes. The data that we collected from North Manchester was using the short form 36 tool. It's a generic tool of health-related quality of life. It's been around since the 80s. It's been used for nearly 20,000 research studies. The data where we looked at the baseline health-related quality of life for individuals pre-operatively versus how their health-related quality of life was it was at a median of, I think it was about 9 months post-op, and that showed statistically significant improvements in the emotional domains of health-related quality of life, as you would expect there to be. And so our sort of future, you know, that shows in the short term, we want to know that continues. So the next thing that Ioannis and I are going to be looking at is revisiting that patient population. So we'll now have 4 years follow-up data, show that it's sustained. And so then, you know, what we're looking to do is to really evidence it, that evidence what we see and recognise already, that this surgery works and that, you know, it helps people to be able to live their life as they wish to.
Yeah, that's so important. You know, it's really frustrating, isn't it? Because you're quite right. We have a duty to spend the public purse wisely, and there will be people saying this is not essential surgery. However, this surgery is available on the NHS, so that decision has already been made. So now we have to decide. Now we have to back up. We know that it works because we've had the pleasure and the honour of speaking to people. Marianne speaks to people all the time about this. So we have the pleasure of knowing that it works, and now we have to back it up. And it is a bit frustrating, isn't it? I wish we had 28 years. So okay, at the moment we've got 9 months of data, and soon we'll have 4 years of data, and then we'll have 12 years of data, which is going to be amazing. But we've started. And that's the really, really important thing, to show people that this isn't aesthetic surgery. This is life-saving, life-improving, life-making surgery. Really important. Marianne, what about, Chloe was talking about things like sexual function, and as well as how you can be confident in the world or the gym or at home. Is that something that you see in post-op patients?
Well, I was going to say, intimacy is something that trans people are frightened to articulate. You know, the idea that they want this, and it will allow them to, have a full active sex life, be close to another person. But I don't, as humans, that's a really important part of our existence. And why would a trans person not want the same conditions to be able to help them to form deep and meaningful relationships? And actually, top surgery, that is something that comes up all the time when I'm speaking to people about it. I wanted to just make another point about something you said earlier as well, if you don't mind. When we're talking about somebody coming for surgery, we did a podcast with somebody who'd been through a vaginoplasty. And she said that the surgeons were more concerned with how well it looked, not how it functioned. And actually, she was saying that this is our body, and sometimes the surgeons aren't listening to us. They're telling us what's best for us. And actually, everything you've said to me gives me masses of hope that actually you're coming from this from a person-centered point of view, and holistic. What is this person actually asking for? What do they want it to achieve for them? Because if we don't ask them questions, we're just going to give them what we want to give them. And so I thought that was really, really good for me to hear as a trans person, that there are surgeons and there are doctors and medical people that are more concerned with the patient than their own ego, I suppose, for want of a better description.
I suppose it's interesting, Marianne, isn't it? Because what Chloe was saying about, we can't do a blood test to see how successful this surgery was. We can't do a scan to show how successful it was. I'm hoping we don't have to measure years of life, because that would imply harm and premature end of life. So we are actually having to look at, how much that life improves, which makes it patient-centered, doesn't it? Ioannis, I can see you nodding. Have you? Does this touch your practice?
Marianne is right. Okay, first of all, we include discussing intimacy issues in our first consultations with our individuals. Okay, we are not afraid to discuss on whether top surgery will improve or not, or will change or alter their sexual pleasure, their intimacy with their partners, their future aspirations in the sexual health. It is part of what we discuss, trying to discover the individual's expectations. So that's one thing and frankly, no physician should be afraid to discuss intimacy in whatever setting that is. It is an important, as Marianne said, it's an important part of our lives. So that's one thing. Secondly, we are discussing about top surgery right now, but we are offering top surgery in North Manchester at least, mainly to trans men. So we are mainly performing mastectomies and chest wall reconstruction, because top surgery in trans women is not regularly offered in the NHS, and I think we should just make a small note of that in our discussion here. I think it's not right. I think it's a discrimination against trans women. I know why NHS is thinking that way, because I think they're thinking that if they offer it regularly to trans women, they should be offering it to cis women too, and that could create a backlog of a huge cohort of patients that would like to have cis women that would like to have a breast augmentation. But I think it's wrong. I think NHS should consider offering top surgery to trans women too.
Sorry, I'm just going to dive in there. I'm glad you mentioned trans women as well. I think for many people, not everyone, but many people, the breast, the chest area is the biggest single signifier of femininity or masculinity. And I don't think we can underestimate the value of that for somebody that is transitioning. And equally, it is for women and men alike. We shouldn't. But equally, most people are comfortable with what they've got. But for some, it is a really important aspect of their very being. So yeah, the main signifier for men and women is the chest area. So I'm glad we're talking about that as well.
All right.
I mean, one of the things that we often talk about here on the GenderGP podcast is the fact that if we were ever able to have a future where the medical intervention that precedes any surgery was given at the right time, and the puberty that someone was able to go through was in line with their gender identity at the time when people normally go through puberty, then we wouldn't need to have male top surgery, and we wouldn't need to have female top surgery. And so that's something that I always aspire for the future, which would put you two out of a job, but very, very in a very welcome way. What about non-binary people? Let's not leave out a very large portion now of the transgender community, and a growing number of people coming forward saying this, that, or the other. Do you have any experience patients who are in the middle of the gender spectrum, as it were?
Well, I think if I'd sort of put this conversation in my sort of preparations coming to North Manchester, an area that has come about much more in the last couple of years of the referrals coming through to our clinic. So it's a part of it that Ioannis has much more experience than me. So I think I'll sort of put over to him on it.
Yes. So yes, thank you. I mean, So non-binary individuals are an interesting cohort of who we see in this clinic, okay? And we started collecting data prospectively in the last 2 years. So right now, our data includes 35 individuals so far. Dealing with non-binary individuals is no different than dealing with binary, with trans men or trans women. WPATH does not differentiate on our approach when it comes to top surgery. So the same guidelines apply. What we need to do is go back to what we said earlier about expectations and trying to meet them, and have an open mind when it comes to discuss outside the binary context, that what I think that it should be an appropriate chest is not the same expectation that an individual might have. So personally, I'm very happy to discuss anything outside what someone else would consider, and I hate that word, normal. So larger areola, different position of nipples, different types of flatness or masculine appearance, it can all be discussed, trying to provide the best outcome we can for our individuals. So I don't think, I mean, right now, some surgeons consider, for example, 2 letters of referral when it comes to non-binary, as opposed to 1 letter of referral when it comes to binary persons. I don't think that should be the case. It's exactly, we're dealing with, we're trying to deal with gender dysphoria. Everything else is irrelevant. So I'm happy to discuss any individual requests with everyone.
I think some people, Ioannis, some that I see on social media are finding it difficult to get that referral to you. And particularly if the non-binary people are worried that that their GP won't refer them to the gender clinic, and that they won't even be allowed to start gender-affirming medication, never mind actually then being referred on for gender confirmation surgery. Do you find that in your experience, or do you not get to see that report?
Well, we get referrals from the GICs. From my experience, there is no discrimination. I have seen referrals from individuals that were not on hormonal treatment, that they had specific requests when it comes to surgery, and there was no issue in referring them to us. I don't know if that's a specific benefit we have in Manchester, okay, because this is how we approach our clients. But I presume it's the same for any other unit in the country. Non-binary persons can be referred to GIC, and the GIC should refer them to the respective unit for surgery.
I suppose the problem is, though, Ioannis, isn't it, is we only see the ones who have breached that barrier and made it through to us. You know, we've got no idea of the ones who don't don't manage to pass that barrier.
That's absolutely true. You're right, Chloe. But I think the barrier comes for if someone is referred to the GIC, because we are in regular contact with the gender identity clinics, they will eventually be referred to us to discuss surgery, and then we can explore the options, okay, based on the individual expectations and preferences.
I think that your very confident statement a couple of minutes ago, Ioannis, is so important. Non-binary people are allowed to be referred to the GIC, and the GIC are allowed to refer them to surgeons, even if they're not on medication. And I think, these kind of statements are going to be really powerful for people who go to their GP and say, actually, I am allowed to be referred. Please do so. This is where it says I am allowed to be referred. And at the clinic, again, having that confidence to say, I am allowed this, please do it for me, kind of thing. And that this, again, Chloe, goes on to what you were talking about with pathways and frameworks, and having those set in stone, which is a work in progress. I'm sure there's a lot of work to do, but it's happening, which is really, really exciting, I think, for the future. Marianne, do you see any people that struggle to get through, or is it...
Well, I struggled to get through, didn't I?
Well, that's true.
So, the reality is that I think the gender clinics, it can sometimes be a lottery which clinicians you see and what their attitude towards non-binary might be, or to even being trans might be, and that the tick boxes that they want fulfilling. So I do think there probably is an issue before people get referred to you, and I think you were right there, Chloe, that you do get to see the ones that have navigated it. That's not having a go at the gender clinics. They're trying to interpret protocols, and the trouble with that is that people are frightened to break protocol. Me and Helen talk about this all the time. Sometimes, somebody comes to me for an information gathering session, and I just think, why are they having to talk to me? It's so clear that this is right for them, and that we've got the strength to do a report. We'll fulfil the requirement, but that this is right for them without question. I don't think that when you turn up at the gender clinics in the NHS, the protocol allows for that. It still says no matter. So I was working as a professional qualified counsellor working in this area, and they didn't see me fit for hormone therapy. To this day, I don't know what I did wrong. I did get it eventually, but so even the most well-rounded person, I just didn't meet the protocol. So I think that's something that, obviously you can't influence, but I think the message should be going out to the gender clinics, to trust you to make the final decision on who should get surgery and whether it's right for them as well. You're the ones that are going to be performing that surgery.
I'm going to move the conversation on, because one thing I talk about is I've seen, again, lots of chat about, and Ioannis, I think it was you who mentioned it, quality of skin. And there are always lots of questions from worried parents about binding, and what's the best or the worst way of binding, because obviously that's what many trans masculine people do before they have the ability to have access to surgery. Have you got any advice to give people who are looking at binders or ways of binding, or parents who are worried about their young people who are binding? Do you have any advice for them?
Yeah, well, binding is a huge issue, okay, and I understand the reason why a person should choose to bind. As Marianne said, our chest is the most prominent indicator of our gender, but it can pose some challenges. Okay, the binder affects more things than just the quality of skin. Affects breathing capacity, affects posture, and in some cases it might alter the surgical plan. So prolonged binding in a chest which is borderline for a keyhole operation, for example, for a periareolar mastectomy, because of prolonged binding and the stretching of the skin that follows, may make that operation impossible. So because of the use of the binder, we might switch to a different type of procedure that might involve more scarring, that could have been different if someone wasn't binding their chest. So my suggestion is to keep binding to a minimum. As I started by saying that I know the limitations and I know what is happening, but we should be looking after, trying to project ourselves in the long run. There are alternatives to binding. Some of them have their issues as well, like using tapes, like using taping of the chest. There are other issues there. Everyone is individual. So quality of skin, for example, the presence of acne should be taken in consideration. Posture should be taken in consideration. What is the expectation in surgery in the long run should be taken in consideration. Generally speaking, please try and keep the binding to a minimum.
And isn't it, when you say about sort of binding to a minimum, Ioannis, it's about minimum of hours in the day that it's worn, rather than like degree of binding, you know? So absolutely recognise it that, you know, it's so to sort of, for it to be in the time, you know, when you're in the home, as much as you can feel comfortable to remove the binding at that times, but yet, you know, to be limiting the hours in the day rather than the compression of the binding.
Can I just ask a question? Would that support the case for speedier intervention as well? So if somebody is on a waiting list for 2 years without the advice about binding, without that knowledge, that actually that's causing them more damage, and that, you know, there is a case for earlier intervention just purely from the long-term ramifications.
I mean, I think so, you know, certainly, gosh, I mean, there are very many reasons why it's not correct that a person waits 2 years, but we're not talking about that, are we? But 2 years of their surgery. But, you know, certainly it will have a deleterious effect on tissue quality. You have less skin elasticity. There will be a greater excess of skin. And the more skin that needs to be, in general terms, the more skin that needs to be removed, the bigger the scarring needs to be, you know, in a pretty simple concept of it. So you have increased skin stretching, you're going to need to have bigger scars to remove that skin. And so therefore, your aesthetic outcomes, you know, will perhaps not be as great as they would be if you were doing it with no binding at all.
I mean, I think the take-home message that I've learned from your valued advice is that we completely understand the importance of something like binding, because going outside, Marianne talked about that gender signifier. So we understand the need, and we understand that is this a thing. We all feel like we wish it wasn't necessary, but we understand that it is. But really, the message is to try and limit it as much as possible, while still keeping your own mental health as tip-top as it can be. So thank you very much for that advice. I'm thinking about the future, where we have robust training in medical school, we have inclusion in postgrad training in the FRCS, which is the exams that surgeons do to qualify to be a consultant surgeon at the end of the day, and then ongoing training. Again, it feels like a long road ahead to have gender-affirming medical care and gender-affirming surgical care in that medical education arena. How are we going to achieve it?
I think small inroads are already being made. One of our colleagues at North Manchester, Kate Williams, she's been invited to be involved in writing a section for one of the breast surgery textbooks, which is part of the sort of core Bible of textbooks in general surgery. So those small inroads are happening. I think from my sort of goals and aspirations of working through is, in the first instance, we are based in Manchester. Manchester Medical School is enormous. You know, it will be making those one-to-one contacts within the medical school, finding out what part it plays in the existing syllabus and teaching of our students, because you know, you need to be bringing in that education at all levels of individual, working through the healthcare system, but particularly it's those people who are coming in at the beginning, for it to be that, this is a part of your baseline, this is your basic medical training, so that all people working in healthcare have that. I can only hope that then there is a trickle effect that goes further outwards. And I think it's something that, us as individuals who work in this area and can hopefully try to sort of inform those wider, changes that go further.
So it sounds, Ioannis, have you anything to say on that?
Yeah, just one more, just a couple of things. Chloe is right. We should start with the medical school, and we should start with education, and we should being in the center of this procedure. We should be in the center of driving the education in all levels as possible. But we also need to come together, all the surgeons in the country who are actually offering these procedures. We should come up with some kind of guidelines on who is offering the procedure and in what terms. I know that our bottom surgeons in London are a bit ahead of us. So there is a process right now to include gender affirmation surgery in the plastic and urology curriculums, and the Royal College of Surgeons is involved in that process. But they have left out top surgery. And we are trying to see how this can be included as well. So things are moving forward. It's important for all of us to be as vocal as we can and drive this change forward.
I mean, I think, the big organizations have to listen to the small individuals that are currently driving the forward. And, it makes us very vulnerable that there are no guidelines for us to follow in the UK. It makes doctors feel quite scared, because there's nothing better than having a nice guideline, the National Institute of Clinical Excellence to follow, or a UK published NHS guidance, this is how you treat this condition, or the Royal College of General Practitioners, the Royal College of Surgeons, in their curriculum, this is included in the curriculum, and every single surgeon or GP or doctor needs to learn this, otherwise you're not qualified to do the job. And so it feels like a long way to go, but it's being driven by the individuals. And I think you're right, what we need to do is get the big organisations behind us to understand the importance. And, the General Medical Council itself, who are the standard setters of education. They are supposed to set standards for education, and we need to look to them to say, please set some standards by which the Royal Colleges and the medical schools and the postgraduate deaneries are able to set standards that then us doctors can feel comfortable to follow. So it feels like a big job, but it's happening, isn't it, Marianne? I mean, we've seen a big change in the voice of the transgender person over the last, say, 5 years, and then other doctors like our guests today coming forward and making changes for the future. We've seen a big change in the last 5 years, haven't we?
I mean, I can't tell you just how excited I am by what I've heard today, because it has been on the fringe. Transgender healthcare, just as a service user, does feel like it's an inconvenience. And, I hear stories about they struggle to get clinicians to want to work in that area. And then you see what happens to some of the people that do. And so to hear that actually it's starting to be recognised, even in a small way, feels to me really hopeful. And maybe it is that there is a wind of change, that it's not a coincidence that we are able to do this podcast today. So I'm just really excited by what I've heard, without question.
Thank you so much for listening. I really hope you've enjoyed our programme today. Please go ahead and subscribe to future episodes if you haven't done so already. If you or anyone else have been affected by any of the things that we've talked about in our podcast today and you'd like to contact us, please visit our website Help Centre and contact us via there. We're very happy to accept ideas for future episodes and future guests, so let us know if there's anything specific you'd like us to cover. You can also visit our website GenderGP.com for a multitude of information about transgender health and wellbeing issues. You can follow us on social media. ID is @GenderGP, and you can sign up to our monthly newsletter. Full details can be found in our show notes on our podcast page. Thanks for listening, and see you soon.